Hello, good morning, everyone. Pardon my perspiration. I ambulated over here, trying to save some trees. But welcome. It's great to be back here for a brief visit to Barnes-Jewish. I'm Carl Wallenkamp. I'm one of the VA chiefs right now. And I'd like to welcome you all to Grand Rounds. My role today is to have the honor of welcoming Dr. Dan Zimmerman here from the Longer Life Foundation. Just briefly to say, he obtained his bachelor's in science and medical degree from the University of Wisconsin-Madison and graduated AOA from medical school. He then went on to do residency in internal medicine and pediatrics and has had a varied career with both expertise in medicine and insurance, which led him to come here to St. Louis in 2014, where he joined the Reinsurance Group of America as their Senior Vice President and Chief Science Advisor, and the Longer Life Foundation as their Managing Director, where he has been since. So help me in welcoming Dr. Zimmerman.
Thanks. Good morning, everybody, and appreciate that welcome. It's great to see some former grant recipients here today, as well as current ones. And so, again, I'd like to, on behalf of Longer Life Foundation, to welcome you to Grand Rounds. The foundation is a collaboration between Reinsurance Group of America, or RGA, we're located in Chesterfield, and Washington University. We're now in our 26th year, and just proud of this long tradition of supporting research into the drivers of morbidity, mortality, longevity, and wellness. So today, it's with great pleasure that I announce our 2024 grant recipients. And they are Rita Brookhart, Gautam Dantas, Ali Javahari, Eva Klinman, Kathleen Markin, Elizabeth Polina, Lindsay Underhill, and Priyanka Verma. Congratulations to all these grant winners, and I wish them success. For more information about the Longer Life Foundation, please check our website, longerlife.org, or follow us on LinkedIn. Our next funding cycle will begin in January of 2025. Information will be provided on the website, including an updated CFA at that time. Now, I'd like to turn things over to Dr. Frazier. Thank you.
Good morning. It's really great to see everybody here this morning. It's my privilege to introduce our speaker this morning, Dr. Laura Marks. Laura went to college at Pacific Union College, majoring in Spanish and chemistry, and then received her MD, PhD degree in microbiology and immunology at State University of New York in Buffalo, New York. We were fortunate to recruit Laura here as part of our physician scientist training program, where she did her residency and short track, then into an infectious disease fellowship here. So Laura is the recipient of a number of honors and awards, and you'll get the distinct sense of outstanding contributions in academic excellence throughout all phases of her training. So at Pacific Union College, she received a full scholarship for academic excellence. She also received a National Science Foundation fellowship for undergraduate research, and the Vera Wynne Award for the senior chemistry major with the most outstanding academic achievements, creativity, and technologic skills. During her MD PhD, she received the Irwin Detter Award for outstanding research. And here at Washington University, as a resident, she received the Outstanding Resident of the Month Award, the Greg Gertner Resident Research Award, the Department of Medicine House Staff Distinguished Service Award, the Knowlton Incentive for Excellence Award, and she was the recipient of the Oliver Langenberg Physician Scientist Training Program Fellowship and the Stuart Kornfeld Fellowship Award as well. Laura is an assistant professor in the Infectious Disease Division in the Department of Medicine. She currently co-directs the Bridge to Health Award. She is an outstanding teacher and has really wonderful teaching evaluations, both for medical students, residents, and fellows. She has a real passion and interest in infections that occur in people suffering from substance use disorders and addiction, and has been very active in the addiction and harm reduction KISC training program here at Washington University School of Medicine. So please join me in welcoming Dr. Laura Marks, who's giving an outstanding talk. I understand she gave it yesterday at the VA, so we know it's really good already. I'm not, reading the future. From Garbage to Knowledge, Understanding Staph aureus Infections in people who inject drugs.
Thank you, Dr. Frazier. So I'm going to talk a little bit this morning about, let me make sure that goes. And my only disclosures I should start out by saying is that I do receive research funding support from the Gilead Focus Foundation, which helps fund our linkage to care programs here for HIV and viral hepatitis. So I'd like to talk about today is the overdose crisis. But we're going to talk about something other than overdose. What we're going to talk about today are the syndemics that come along with this public health crisis. And so we're going to talk about sexually transmitted infections, viral hepatitis and HIV. But what we're going to focus on the most are some of the invasive bacterial and fungal infections that can occur in people who inject drugs. Now, I would love to say that we're going to talk about wound botulism or tetanus or even an exciting hepatitis A outbreak or maybe the anthrax that occurred in Europe in the early aughts or leishmania that happened in discarded syringes over in Spain or even the HIV outbreaks in Indiana. But what we're going to talk about today instead, and what I'm hoping I can convince you is almost as exciting as leishmania in a syringe or an injectional anthrax outbreak, is Staph aureus, the elephant in the room, because this is the one that affects almost every single one of our patients. And in fact, people who inject drugs are 16 times more likely to be infected with an invasive Staph aureus infection than their peers. And these infections continue to grow not only across the United States, but across every country where we see a high prevalence of injection drug use, now accounting for almost 10% of all invasive Staph aureus infections. And so what I like to do as a physician scientist, and what I really structured my career around, is trying to understand the pathogenesis of this disease, take that information back to the bedside so that we can improve our immediate care for the person in front of us, while at the same time thinking about those broader principles, developing and implementing and disseminating them back into the wider healthcare community. So with that, I'd like to have you think about Staph aureus infections in people who inject drugs as its own unique clinical subphenotype. And we've fought with this idea for a while, and it's only recently begun to be really widely accepted in the literature. This was a major publication that came out in Clinical Infectious Diseases recently, and I really love it because it takes a number of different prospective Staph aureus clinical trials, and it comes to the conclusion that most of us who work at the bedside have known for a while, and that's that all of our patients are not the same. Staph aureus bacteremia in an elderly patient with multiple comorbidities is a completely separate disease from Staph aureus bacteremia in a young 20-year-old who injects drugs. It's got a different pathogenesis, it's got different clinical features, it's got different outcomes, and it needs a unique tailored approach. And this is how we think about personalized medicine and the way that we start to implement personalized medicine in our careers here. So when we think about this in the epidemiology here at BJH, this was a study that I did in partnership with Juan Calix, where we looked at the epidemiology over a 5-year time period. And what we saw is that BJH is just like every other hospital in the United States, in the sense that we're seeing an evolving and increasing number of Staph aureus infections related to substance use disorders, and that just like they saw in that publication, our young patients who inject drugs that have a Staph aureus bacteremia, they're younger, they have multiple metastatic sites of infection, they have prolonged durations of bacteremia, and yet, despite often not completing standard of care antibiotic therapy, they tend to have better outcomes. They're younger, they've got better substratum. And so what we wanted to do was take that information back about this disease as its own unique clinical subphenotype and see what are some of the drivers on a microbiologic perspective. If we're thinking that this is its own unique disease, then we need to think about its unique pathogenesis and its unique transmission within our communities. And so we went ahead and we sequenced over 156 isolates of Staph aureus bacteremia from people who inject drugs and compared them with controls that were date and time matched. And then we thought about where these infections came from. And one of the things that immediately pops out when we start looking at this is that our control patients are, not surprisingly, pretty unrelated within our phylogenetic tree. But our patients, our strains from patients who inject drugs, immediately start to group into multiple clonal clusters. And these clonal clusters are temporally related and related geographically. And in fact, when we look at the characteristics of patients within those transmission clusters, they all have characteristics that make us think about shared use of drug equipment. They're more likely to be infected with viral hepatitis. They're more likely to, compared to their injection drug use peers. They're more likely to be infected with HIV compared to their injection drug use peers. They're more likely to have really long durations of bacteremia. We cut it off here at 5 days, but we've seen someone be bacteremic for over 100 days here. Welcome to my life. You know, all of this really starts us thinking about the fact that there are unique clonally propagated transmission clusters within our injection drug use community, many of which are when strains that have fewer canonical Staph aureus virulence factors, so maybe that's why our patients are tolerating wandering around with them for ages and ages and ages. And so this isn't unique to St. Louis. Like I said, our hospital is a small microcosm of what's happening throughout both the United States and multiple other countries. This was a publication that just came out showing the same thing in Bristol, that there's clonal propagation of invasive Staph aureus strains among their patients there in the United Kingdom. And it really drives us to start to ask the question, what's driving this clonality of Staph aureus bloodstream infections in people who inject drugs? Is there a role for access to sterile drug use equipment here? And how can we use the information from these questions to help us improve patient care and patient outcomes? So we started early on in the COVID pandemic by taking a pause and using the opportunity to ask our patients some questions and to hear about their experiences when they're using drugs. And we had an amazing fellow here, Dr. Nathan Nolan, who's now an instructor in infectious diseases and attends over at the VA, who loved meritive medicine and wanted to sit down and interview our patients that were here in the hospital with invasive infections about the way that they use drugs, what their barriers to care had been, what their experiences in the healthcare system had been, and what type of access they had to sterile supplies. And I don't think the results here are going to surprise anyone. We are in a red state. We sit here in Missouri. It is challenging to access sterile supplies for many of our patients, and most of them had little to no access, or were driving into Illinois, or were driving far out of their way from rural areas to come up here to Mo Network or other different small locations where they knew they might be able to access needles and syringes. But many of them did not have regular access. And instead, we started to hear about practices that might make some of you a little bit worried. And we took those experiences that he heard about from these qualitative interviews, and we turned them into a survey that we administered to 68 different clinics across the United States as part of a large national epidemiologic survey that goes out to multiple opioid use disorder clinics. And we had over 1,200 patients who inject opioids respond to this. And what we saw is that the experiences, again, of our patients here at Barnes-Jewish Hospital were not unique. Many of our patients had engaged in behaviors that absolutely put them at risk for invasive infections. What we heard from our patients when we were doing narrative medicine interviews is that many of them would try to avoid the hospital by taking care of their own abscesses. Okay, that's not news to anyone here, but go a step deeper. Ask them what they do with those syringes and needles after they've drained an abscess. This came about by off chance. One of our patients described it to us, and then we asked further. And up to 10% of patients in this national survey, or 9.9%, said, yes, I've drained an abscess and then used that same needle and syringe to inject my drugs. Well, that's a good way to get an infection. Many of them said, yes, I've absolutely shared drug use equipment with people who were sick at the time. Yes, I have shared needles with other individuals, almost half of patients in this 1,200 patient cohort. Yeah, I've used saliva to lubricate a dull needle. So all of these things are things that we think about as risk factors for infections. And honestly, some of them seem like a pretty darn good way to spread an infection to me. So we use this information that we got from this large national survey to move back to those thinking about that syndemic framework, about the different diseases that can cluster within an opioid crisis, and to develop a hypothesis about the way that Staph aureus bloodstream infections could be circulating within our injection drug use community, and wondering if it's more than just the skin. Is this a disease that can arise from multiple sites, from skin colonization, from shared drug use equipment, from non-sterile drugs? And so we hypothesized that many of these routes do not seem to be mutually exclusive, and many of our patients might be at risk for infections from any and or all of these. And so with funding from the Longer Life Foundation, we developed a prospective study here at BJH to try to evaluate these hypotheses. We consented 100 patients that were enrolled to BJH with Staph aureus bacteremia, 50 control patients that were matched with 50 patients with recent or ongoing active injection drug use. And we had our patients who inject drugs take that same validated survey that we had sent out to those 68 different clinics across the United States. And then we had everybody go ahead and be swabbed for skin colonization, nares colonization, axillary colonization, same sites that we usually think about, and collected their Staph aureus isolates from there and from their bloodstream isolates from the microbiology lab. But then we went a step further and we said, go home, take a self-swab kit, swab your drugs for us, swab your drug use equipment, mail the swabs back in, we'll pay for the envelope. We want to know what's in your own drug supply. Let us take a look. And then we said, let's take a look at the community too, so that we can try and match these isolates up and see where these infections are coming from. And this is just a slide of our study participant demographics. There's no huge surprises here. Those thoughts about that clinical subphenotype of patients who inject drugs being more likely to be younger, being more likely to have prolonged durations of bacteremia, with metastatic sites of infection, all of that holds up. Welcome to our demographics here. Our longest duration of bacteremia in our patients in this study was 37 days, so not too bad compared to some of my heavy hitters that have gone close to 100, but really, our patients have a really long period of bacteremia with lots of opportunities to spread this to others. All right, we partnered with an amazing basic science lab, Drew Schwartz's lab. He's a brand new assistant professor in the Division of Infectious Diseases, Pediatric Infectious Diseases, came up through the PSTP with me to take all of these strains back, go ahead, sequence them, assemble them, and tell us what matched. Were there similarities between patients' skin and bloodstream isolates? Were there similarities between drug use equipment and their blood isolates? Was it that their blood isolate matched with someone else's blood isolate? Or what about those drugs from the community? So this won't surprise anyone. Our colonization rates in people who inject drugs were pretty similar to national estimates, which have varied from everywhere from about 20 to 60%, depending on the season. There tends to be some seasonal variation there with higher colonization rates during the summer months, and similar colonization rates between the controls. But what we did see was that not all of our patients who inject drugs were colonized with the same isolate that was in their bloodstream. But they often did have it. So we did see many cases of infections where that bloodstream isolate lined up perfectly with that skin isolate, but sometimes it didn't match to the skin isolate. So then we're left wondering, where did that infection come from? And that's where our drugs come in. So we had 6 patients out of 50 return their home drug swabs, which you're gonna say, that's a pretty low rate. But honestly, when over half of our patients don't have a home to go back to swab their drugs, I was actually pretty pleased with that. Of those 6 that came back, 3 had Staph aureus in them. 2 of those were genetically related to their bloodstream isolate. And we said, okay, this is cool, but it's not enough. So we partnered with Dr. Nolan again, who runs an amazing community outreach organization here called StreetMed STL that provides harm reduction education to patients without stable housing who are living in many of our encampments. as well as wound care. He does amazing wound care out on the streets, and importantly, helps remove discarded injection equipment from these sites and will help pick up large sharps containers and take them for safe disposal. Some of which happens in our laboratory, because he brought us back lots and lots of different sharps buckets with discarded drug use equipment that we could then use as our research fodder. Because when you're a junior professor, pennies count, and what could be cheaper than garbage? So that's my pro tip there. So we took these discarded drug use equipment and we said, let's find out both what's in it on a microbiologic side and also on a chemical side. What are our patients injecting? Is that linked with the bugs that are in there? What's actually in a syringe? And so when I talk to patients, I remind them, they'll tell me, oh, I don't need opioid use disorder treatment. I only inject meth. Well, you inject a powdered substance that may or may not contain any variety of things. So while street drugs don't typically come with an ingredient list, I made one up for you. So this is what our ingredient list would look like for a syringe here in St. Louis. And welcome to the different things that we love to see. You've got a nice side helping of fentanyl, really important, but add in a side of methamphetamines, lots of xylazine, and really important, have some fun with quinine. This has been a staple of the drug supply since the 70s. When there was a malaria outbreak in the 40s in New York City, and someone had the bright idea to throw some quinine in to help control that amongst people who are injecting heroin, and because it's got that nice bitter taste, it just never left the drug supply. It's a great agent to cut with, and this remains true even in 2020 in the fentanyl supply. You've also got some other fun agents in there. But really importantly, you should know that this was not manufactured in a sterile facility. There may be peanuts, but more importantly, there may be biologic contaminants, including live bacteria and fungi. So this is what our workflow looks like in the lab. We get back these big boxes of discarded drug use equipment. From our encampments, we safely sort out our capped needles and syringes. Anything else gets tossed because we're not interested in what's on the outside of a syringe. I'm not interested in what's on the outside of someone's sharps box. I'm interested in what's on the inside of an airtight, capped, and sealed syringe. We'll swab that and we'll put it on some plates. And you can see here, it's kind of nasty. I'm just gonna throw that out as a qualitative observation. So almost 60% of our syringes grew at least one type of bacteria, and this is not scant growth. These are not sterile. The drugs that our patients are accessing, this comes from a contaminated drug supply, both in terms of the chemical composition of that drug supply, which we talk about a lot in the news. We talk about xylazine. We don't talk about as much about quinine, which makes me sad because I think it's cool. But what we don't often talk about is the biologic contamination of our drugs. So this isn't new, though. This has been seen as early as the 70s. This was a fabulous article from 1972 that you can look up in the library on contaminated street heroin, its relationship to clinical infections, that was published, and then followed up in the early aughts where someone was like, you know what, let's swab some heroin again. And they tend to do this whenever something really cool like tetanus or anthrax shows up in the drug supply, because what ID doc isn't get excited about anthrax? Like, it's just hard not to. But the elephant in the room, and what has been consistently seen in all of these publications, is that there's a ton of Bacillus cereus. We know that causes eyeball infections in our injection drug use population. Lovely agent to cause infective endocarditis, go straight to the eye. We've had 2 patients lose their eyes here from that. A lot of Klebsiella, Pseudomonas, and then a ton of Staph aureus, one of the most common infections that we see. So we took these isolates, we separated out our injection drug use isolates. I'm not showing any of our control isolates here because, you know, while that's cool, it's not quite as much fun as garbage. But when we map out some of our isolates that come from these outreach supplies, what we start to see is that they match up really well. And what I'm showing you here is only isolates with a CG SNP distance of less than 25, and how these community isolates that we recover from discarded drug use equipment line up with the isolates that we see in our patients' bloodstreams, and then line up with other subsequent bloodstream infections. So what we're seeing is that infections in people who inject drugs can come from their skin, they can come from their drug use equipment, and they can be shared between different patients, and they can connect within those different networks. So that was really cool. We have this information. Let's go back to those surveys that our patients took. You know, are patients that are at the center of these little clusters, are they the ones that said, I've never in my life shared needles or syringes, I always heat my drugs, I boil them up until they're good and sterile? No. Our patients are just like other patients around the country, except that they had a higher rate of non-sterile drug use practices, which isn't surprising when you think about our national epidemiologic survey going out to people that are in substance use disorder recovery programs. They don't have a current active infection. Now, they reported a high prevalence of infections in the past in that national survey. Up to 60% of them said, I've had an infection at some point in time, with 10% having reported bacteremia. But all the patients that take this survey here right now that you're looking at were patients with Staph aureus bacteremia. And what you'll see is that 18% of them said, oh yeah, sure, I've drained an abscess and used that syringe to inject my drugs. I've shared with someone who has a fever or is sick. I don't clean my skin. No one's told me that's important. And so without regular access to sterile supplies, we see a high prevalence of these behaviors that are really going to put patients at prone for invasive infections. And the patients that are at the center of our transmission clusters are absolutely patients that are reporting these behaviors. Now, if we look longitudinally, we've now got a great library of strains that have gone from 2016 up to 2024. What we see is that our patients who inject drugs are going to be at high risk for recurrent infections, and they're going to be at high risk for recurrent infections within these clonal networks. So I want to take that information and step back a moment and say, how do we then use this to help take care of patients? And I think the most important thing that I can take away from that is that the infections that our patients derive can come from multiple sites. We talked about this already, but I'll just remind you, they can come at any point in this drug use cascade. They can come from the drugs. They can come from the drugs being dissolved in solvents. They can come from the drug use equipment. They can come from the drug use behaviors. As you inject yourself into your veins, did you clean your skin? And then you can enter back into that cycle again where those drug use syringes and needles serve as fomites for that infection to either be passed back to you or to be passed to your neighbor. So we're going to move 3 steps back now because we got garbage, both from our friend Dr. Nolan, but also from a couple of syringe exchange sites around the area. So we passed out take-home swab kits over at the T back in 2020. So if you came in for a hot shower, use the internet, whatever, you could take one of our self-addressed envelopes, swab your home supplies, and mail it back to us for a gift card. We also got some garbage from Mode Network. We got garbage from everywhere because garbage is a junior researcher's dream. And I think it's really important to go ahead and compare the contamination rates here. I won't bore you with the details of what's in all of these different syringes because at the end of the day, it's pretty darn similar. There's a lot of staph, there's a lot of Pseudomonas, there's a lot of B. serious. We have to get serious about B. serious. But overall, what we see is that our syringes that are analyzed from patients that don't have regular access to safe supplies. These are our patients that are in our homeless outreach encampments. Those are our syringes with the highest rate of contamination. We're thinking 58% here. Whereas if we go ahead and we analyze garbage or our discarded drug use equipment from syringe exchange facilities, that contamination rate drops down to 33%. And I sort of think of this as modeling some of the early studies that they did with syringe exchange back in Connecticut in the late 80s and early 90s when they were thinking about how syringe exchange impacts rates of HIV transmission. And in those studies, they went ahead and they looked at those syringes and they said, if we get HIV contaminated syringes off the street, we're removing those from circulation and helping stop the propagation of this virus. And I think of this the same way for Staph aureus. The more times a syringe and needle is in circulation, the more opportunities it has to pick up pathogens through non-sterile injection practices, through non-sterile drugs, through non-sterile solvents, through the fact that every single step in this cascade is often not sterile. methamphetamines are not manufactured in a good manufacturing practices facility where someone is wearing the bunny suit and they've got the hairnet and they're washing their hands and everything. There is not multiple steps where infection prevention is looking through the pharmacy to make sure that it's distributed in a safe and sterile manner. It's not being made up with sterile saline sachets for the most part by most of our patients. And so removing these contaminated syringes from the broader drug use consumption really makes us think about how this can impact our patients' outcomes. So I love this quote from the publication that Dr. Nolan did, and it just makes me think about the fact that our patients want this information. Even if they're not asking you for it at the moment when they come in and they're septic and they're sick, a couple of days later when they're getting better and he interviews them here in the hospital, they want that information. They want to know how to be safe. Because while some people enjoy a stay at hotel bars, for the most part, when you're sick here, nobody really loves to be sick. All right. So if our patients want the information, how are we doing as physicians with providing it? Now, I won't address the larger group of physicians within the U.S., but we did survey infectious diseases physicians through what's called the Emerging Infections Network. It's a network that goes out to many different attending infectious diseases physicians across the United States and allows us to get some information on different practice patterns. And so we asked those of these physicians who cared for patients who inject drugs how they feel about harm reduction counseling, how often they're incorporating it into their regular care for patients. And what we heard was that less than half are incorporating it routinely into their care of patients who inject drugs. And most of the time, it's because they don't feel comfortable. They don't think they have the education to do this. And what I'd like to convince everybody by the end of this talk is that you absolutely have the education to do this. We are all infection preventionists at heart. We love washing our hands. It's great. And the education that we provide our patients doesn't have to be fancy. It can be small, basic steps that make a real difference for patients. So teaching people about what they refer to in this publication as the 6 moments of infection prevention in injection drug use, to kind of mirror the idea of the different moments of infection prevention that we think about here within the hospital. And it can be as simple as statements like wash your hands with soap and water, use alcohol pads to clean your skin before injecting, rotate injection sites, use sterile equipment. When I'm giving this information to patients, I love to incorporate our nurses. I like to tell patients that everyone here in the hospital, we want to make sure that we do our very best to take care of them. And that means we're going to try to not give them an infection while they're here. Our nurses get special training all throughout nursing school about how to use medications in a sterile manner. They place IVs in a sterile manner. They inject medications in a sterile manner. Because at the end of the day, it's not injecting drugs that's inherently dangerous. We inject drugs all the time in the hospital. It's just that we inject sterile drugs. And we inject sterile drugs with great hand hygiene, hopefully. Everyone's washing their hands. And with access to sterile supplies. And so I love to have our patients think about the idea, and I usually do this with the nurse in the room so the nurse knows that I'm doing this, that your nurse is taking great care of you. Before she places an IV, he or she places an IV, they're using hand sanitizer outside the door. They're putting on gloves. They're cleaning your skin to make sure that they've removed any of the staph there and decreased the chance that you get an infection. And I want you to have this information, even for our patients that are in substance use disorder care. I want you to have this information so you can keep your friends safe, so that you can keep yourself safe in the future, because you don't have to get an infection every time, and there are steps you can take to help reduce your risk. So how does this play out in practice? Well, there was an amazing team over at Boston University Medical Center that set up a randomized controlled trial of an intervention aimed at reducing infections in patients who inject drugs. It was called the skin intervention because they are much better at me than acronyms, even before the advent of ChatGPT. And they looked at different hospitalizations that these patients had over a 1-year period after patients were randomized to the skin intervention to teach them all of those core steps, which again, these are not fancy steps. They're things like washing your hands, cleaning your skin before you inject, having access to sterile supplies. And how did this play out in practice? Well, what they saw is that shared injection. They surveyed people after they came back and after they'd had multiple readmissions, and that shared injection drug equipment was common, and anytime someone used that, they had a 2.2-fold higher incidence rate for skin infections. But if they shared needles as well, that incidence rate bumped up to 3.3%. So the idea here is that a skin intervention can make a difference. Teaching patients about harm reduction can make a difference because we know that using shared needles and drug use equipment contributes to skin and soft tissue infections in our patients. And so with that, I'm going to take one step further into our clinical care for patients, because I think all of this basic science information that we've developed really helps us reframe our infectious diseases care for patients who use drugs and allows us to think about maybe approaching each clinical encounter with some of these overarching principles. And this is from a fabulous manuscript that Aisha Appa and Elise Worcel put together, where they really try to reframe care in terms of harm reduction, health equity, shared decision-making, and the idea that there can't be a wrong door for accessing care. Whether or not our patients come into the hospital for a non-fatal overdose and we find out that they're bacteremic with Staph aureus, happens all the time. Or they came in because they accidentally tripped and fell into a manhole cover. Also a true story. And they're bacteremic with Staph aureus bacteremia and they need substance use disorder care. Our patients have to know that when they come in, there's no wrong door for accessing care, whether it's here at the hospital or an infectious diseases clinic or a substance use disorder clinic. All of those roads need to lead to arming patients with the tools to stop the cycle of invasive infections. And so with that, I'm going to use infective endocarditis as an example of how we put this into play. I was really privileged to be a part of the panel that put together this scientific statement from the American Heart Association on best practices in care for patients with infective endocarditis. And I love this statement because I think it really summarizes some of the best practices and reframes the care that we can provide these patients. And it's one of the few cardiology publications I see where the guidelines don't actually start out with the heart failure management or the CT surgery management. They start out with the substance use disorder care, and then they move into the harm reduction education. Because if we don't think about those fundamental principles first in our patients who have infections related to the act of injecting drugs, then anything we do down the road with CT surgery doesn't make a difference. We have to make sure that we've addressed the root cause and that we've armed our patients with the opportunity for better outcomes in the future. And part of that also means connecting our patients with substance use disorder care, because we know that substance use disorder care saves lives. Medications for opioid use disorder are associated with a mortality benefit after hospitalization for infective endocarditis. And if you're going to do it, it doesn't really matter what you do as long as you make sure that that patient has access to ongoing care after they leave the hospital. The hospitalization can't be the end of that care. So here's just a quick excerpt from this AHA statement. In case you're a cardiologist, or if you're like many of our internal medicine residents and you're hoping to be a cardiologist someday, just know that your American Heart Association is also hoping that you're a harm reductionist too. So you can take these principles back to the patients on your cardiology firm and know that even if your patient isn't interested in stopping using drugs today, that's okay, because we're going to arm them with the principles to help them keep themselves safe in the future. And if they are interested, that's amazing. We've got fabulous addiction medicine teams here in the hospital through both the psychiatry consult service and the toxicology consult service that are excited about getting your patients connected to substance use disorder care. The other important part about the way that we can reframe an approach to these infections in patients is thinking about them, again, as a clinical subphenotype and recognizing that there doesn't have to be one right antibiotic option for this patient population, and that instead we have to be flexible and we have to take a more individualized and personalized approach to care for this patient population, because not everybody is going to find 6 weeks of IV antibiotics here in the hospital an accessible option for them. And if that's what they're telling you, then we have to be able to pivot and to make other evidence-based approaches to make sure that we complete out their antibiotic therapy and cure that infection, because nobody deserves to wander around with a bloodstream infection. It kind of sucks. So this was some research that we did here at BJH where we looked at 238 patients that had injection drug use associated Staph aureus bacteremia, and we looked at whether or not they got no antibiotics, or did they get a early transition to oral antibiotics, or did they stay here in the hospital for ongoing IV antibiotics? Just the same way that we think about within that AHA statement. And what you'll see here is that giving someone no antibiotics is always a bad idea. You know, this was an infection with a really high mortality rate in the pre-antibiotic era, and that hasn't changed. Despite the fact that many of our Staph aureus bloodstream isolates within the injection drug use population lack some of the canonical virulence factors, they're still pretty gnarly, and they will still kill you if you give them enough time. Now, that said, just because we're going to transition to oral antibiotics does not mean that we don't need to be thoughtful about when we do it. So what we've done here is we've broken this information down by when our patients transition, whether they transition early on between prior to clearing their bacteremia, or if in outcome B, they transition before the end of that first 7 to 10 days, or in option C, they transition after 10 days, the same way that we think about this within the POET trial. And what we see is that if you can get someone to 10 days, they'll do fine. But you have to make sure that you've given the patient an opportunity to clear their bacteremia. Everyone deserves source control, and everyone deserves to make sure that they're tolerating antibiotics before they get transitioned. And if we can accomplish those tasks, then we can tell our patients, if you require a flexible antibiotic option, and again, I still offer 6 weeks as my default upfront to patient, but if that doesn't work for you, we have other safe options that we can use with close monitoring and close follow-up to help get you through your antibiotic therapy and help provide safe and effective care for you. Now, the last part of this AHA statement is actually about the other syndemics, because we wanted to be holistic in our thought process of caring for patients with injection drug use associated endocarditis. You'll remember that first slide I put up here and thinking about the fact that these bloodstream infections, they don't occur alone. Many of them are going to occur because of non-sterile practices. They're going to occur because of shared drug use equipment. And because of that, our patients are at risk for many of these other infections. They're at risk for bloodborne viruses like HIV and viral hepatitis. They're at risk for sexually transmitted infections. So we want to use these admissions as an opportunity to screen for HIV, to screen for syphilis, screen for Hep B and C, throw in a gonorrhea and chlamydia test, and please make sure that you treat any of these infections that come up. 6 weeks of IV vanc does not cure your syphilis, so if you've got a positive RPR while it's here, let's throw in some bicillin. Here at BJH, we want to make this easy for you. So we've partnered with a fabulous hospital medicine physician, Ben Homan, and then Madeline McCrary to develop a in infectious diseases, to develop a best practice advisory to make it easier for everyone to adhere to some of these best practices. Because if you look at this long list, this is a lot of things to do in an admission when I'm thinking about trying to sort out, has the Staph aureus bloodstream cleared, infection cleared? Have I talked to CT surgery about if this patient needs a new valve? Did I consult addiction medicine? And we think of all these very immediate needs, and screening for syphilis really drops down low on our priority list. And remembering when the last time they got checked for viral hepatitis sort of falls down. And I don't know, someone should have offered them HIV testing in the ED, but they were also sick as stink at that moment. And these things tend to get lost. So we've used an electronic medical record. We've tried to power it for good as much as sometimes I hate my inbox and the extra clickies. We've tried to use it as a force for good today to remind patients that remind clinicians that their patient might be at increased risk for these infections, show them the last time they were screened, and prompt them to consider if they would like to offer additional screening today. Now, if you choose yes, you should know that your patient, if they're uninsured, will not be charged a dime. That funding, those tests get passed back on to the cost through the Gilead Focus Foundation grant. And patients are all connected to free linkage to care if they test positive. So you don't even have to know what to do with a positive hepatitis test result. We'll take care of it. You test, we take care of the rest. As a result, I think we are now the largest supplier of direct-acting antivirals for hepatitis C in the state of Missouri, the pharmacy here. So clearly we're doing something right with these test results. And many of our patients, we want to make sure that we've got opportunities to follow them up. So if we're going to do something different with their antibiotics, if we're going to do something different with their harm reduction, we've tried to partner with our inpatient teams, and our infectious diseases consult service will automatically alert us of any of the patients that match this description so that our integrated bridge program can see them and provide that dedicated harm reduction counseling for you. We'd love for every physician to feel like they have the chance and opportunity to be able to provide that education. But if realistically you're swamped, we'll take care of it for you and provide that harm reduction education, help make sure we've got a good plan for substance use disorder care after you leave the hospital. And if your patient needs to leave on flexible antibiotic options, make sure that we're following them up. And again, we love treating Hep C because it goes together like peanut butter and jelly with some Suboxone, and provide case management support. This has been really successful here at BJH. I think we've now had over 800 patients pass through our program over the last couple of years, which just tells you about the depth of need of invasive bacterial infections locally. And with that, I would just like to end with this quote that one of our patients gave us about really trying to make changes and using that knowledge to help keep themselves safe in the future. And with that, I'll take any questions.
Laura, thank you so much. That was a terrific talk. We have time for a few questions.
I had a question. It seems like a lot of the focus is on people who have had an inpatient hospital stay, but we know that a lot of the touch point for people who inject drugs obviously is in the ER with a non-fatal overdose or infections and then get discharged or whatnot. So what kinds of collaboration or programs, excuse me, are there at WashU BJC with specifically the ER patients?
That's a great question. So the question was about the fact that many of our patients who inject drugs and have complications from it aren't always requiring an inpatient hospitalization as their touch point. They may require just an emergency room visit, and that's their touch point with the healthcare system. Oh, yes, and I forgot to mention, we've got fabulous funders, both Washington University Medical Center, the PSTP, and the Longer Life Foundation, who's sponsoring today's grand rounds, and get your CME. So for patients that are using the emergency department as their touchstone, one of the things that I really love about St. Louis is called the EPIC program. So that's engaging patients in peer support and helping link them to substance use disorder care. The emergency department does a fabulous job of alerting EPIC about different ED visits for patients who use drugs, whether it's injection or insufflation. Now, every one of those peer coaches has some different level of training, so not everyone is going to feel as well-versed in different types of harm reduction strategies, but overall, they do get similar training through the state and get linked up with substance use disorder care. And we do partner with the emergency department, so if they happen to test for any of our bloodborne viruses, we do take care of the rest and reach out to those patients and get them in for hepatitis C treatment, usually within about 10 to 14 days in our infectious diseases clinic. We've got special rapid start spots saved for them, just the way we think of our HIV rapid start. So they come see us on Friday afternoons. Hey, Andre.
So one of the latest news that's happening nationwide is a dramatic drop in the deaths due to overdoses, with a 34% drop in Missouri alone. How do you think that's going to affect the way we see patients here in the hospital?
I'm really excited about this. So the question was about the recent news that came out that for the first time in ages, overdoses dropped, which I think is amazing. And it teaches us that at least something that we're doing in this country is working. I don't know what, but something is working. And there's a lot of things that have happened recently. However, I don't think it negates any of the thought process that we need to be doing to caring for patients with invasive infections, because it just means that our patients are living longer, which is great news. But as you live, you're exposed to more infections. And so I think that it means that we have to be increasingly cognizant of the complications, particularly many of the infectious complications that our patients who use drugs are at risk for, because hopefully they're going to live long enough to see them about us and for us to treat them and to help make them feel better. Other questions?
So Laura, that was really a great talk. When you think about dissemination and implementation science and sort of how you hardwire things to actually happen in the way that you want, what currently exists for us to give residents, faculty in the ED or in clinic or on the inpatient service to make this more automatic or easier for them to implement in the moment?
Great question. So I think our first step with doing that was building these types of bundles of electronic medical record advisories, and then helping train patients, helping train residents about best practices and what to do when those results go back. But I think we still have a lot of work to do with bringing that information to all of the different touch points that our residents are seeing patients at, whether that's the inpatient hospital encounter where we've built some of those hardwired practices in, to maybe making that next step over in clinic. And that's a very well taken point.
That's great. Any other questions? If not, thank you so much.